Yes, sir. Yes, Dr. Ahmed, please.
Thank you. So today I'll actually be discussing a case for ID CPC from my own ID fellowship. So thank you everyone for joining in. So we'll get started. The title of today's ID CPC is Finding Nemo in Hyperspace. There's Nemo. So the chief complaint for our patient was abdominal pain and black stools for 1 week and dyspnea and cough for 1 week. The HPI was that this was a 61-year-old lady with a past history of stage 3 right breast invasive ductal carcinoma that was triple negative on their hormonal assessment, but she had undergone a bilateral mastectomy back in 2019, and this is actually a case from 2019. So just to give you a sense of time, and she had been receiving the ACT regimen, which included doxorubicin, cyclophosphamide, followed by her third cycle of paclitaxel, which she was undergoing back in about March 2020. This course for her breast cancer and chemotherapy was complicated by paclitaxel-associated pneumonitis, for which she was started on a prednisone taper. Following this, she thereafter presented with abdominal pain, GI bleeding, shortness of breath, cough, and acute hypoxemic respiratory failure. Just to explore this Taxol-related pneumonitis a little bit, so this was essentially 6 weeks. This event happened 6 weeks prior to her hospital admission. When she was receiving or after receiving the Taxol cycle 3, she developed shortness of breath and new hypoxemia. And at that time, she had some CT chest bilateral interstitial and ground glass opacities. Her bronchoscopy had negative cultures. So the thought back then was that she had developed Taxol-related pneumonitis, which is a commonly reported issue.
Dr. Amir, can you go on slide mode? You know how to go on slide mode? Because the audience is saying that they want it on slide mode. You know how to do it?
I don't think so.
Okay, so we are not able to do that, so you'll have to bear with us. I think this is done.
Okay, that's done? Okay, sounds good. So essentially was receiving the Taxol therapy, then developed shortness of breath, new hypoxemia, had a CT chest with bilateral interstitial and ground glass opacities, had a bronchoscopy done to evaluate for infection, and all her cultures were negative at that time, routine cultures, AFP and fungal. And thereafter, her pulmonologist diagnosed her as having Taxol-related pneumonitis and started a prednisone taper with an improvement in her respiratory status and her CT chest. Her prednisone was originally started at a dose of 80 milligrams and over weeks and weeks tapered down to 60 and 40, and she was kept on TMP SMX prophylaxis for PJP. Now, following this prednisone course, she thereafter developed 1 week of epigastric pain, which that was worse with food. This was while she was on her steroids, and she had black tarry stools for 5 days. Along with this, she had 1 week of progressive shortness of breath, new dyspnea on exertion, and associated dry cough. She had no chest pain or leg swelling. Her past history is just for the breast cancer, for which she's undergone mastectomy and chemo, and she has some diabetes as well. Her medications just include her insulin, her Taxol, paclitaxel, which she's receiving cycle 3 for, her prednisone taper, and her TMP SMX prophylaxis. Regarding her social history, she is, and I should probably mention at this point in time that this was during my ID fellowship in the US, so it's in that geographic context. So this patient was originally from rural Mexico, and she'd been living in the US for the past 7 years with her daughter. She was a homemaker, no history of tobacco, alcohol, or drug use. She did visit her family in rural Mexico once a year, and when she used to live in Mexico for the majority of her life, they used to own and live on a farm where they grew corn and had cattle. She reports no sick contacts, no known TB exposures, no animal contacts otherwise, or any unique exposures. On her physical examination, initially when we saw her, she was afebrile, blood pressure slightly on the softer side, a little tachycardic, tachypnic. She was hypoxemic, requiring 4 liters nasal cannula oxygen, and she did appear quite ill and in distress. She was tachypnic on her lung examination, and she had bilateral crackles throughout all her lung zones. Her abdominal examination was remarkable for epigastric tenderness. The rest of her examination was unremarkable. She was neurologically intact and had no rashes. On her blood work evaluation, I'll pause here for a minute so you all can take a look. Just to highlight some of the findings, there was a leukocytosis with a left shift. There was anemia. Her hemoglobin was down to 7.7, and she had some electrolyte troubles. And by and large, that was it. Moving on to her CT chest. So on the right-hand side of your screen is her new CT chest, and on the left-hand side of the screen is her old CT chest. So I'll pause here and I'll ask one of the fellows to comment on the new findings that you're seeing on the CT chest on the right-hand side.
So fellows, bilateral or coarse fluffy infiltrates throughout scattered all over the both lungs.
Sounds great. Any other comments?
I'm going on the list to see who the fellows are. Shakil has unmuted. Ji Shakil.
Yes, so same bilateral fluffy infiltrates, and it looks like honeycombing-like pattern. With bronchiectasis like features are there. Bronchiectasis like, and there is some emphysematous changes mild is also there.
Bilateral ground glassing with the background of nodular opacities in the
Sounds good. Thank you so much, everyone, for those comments. So it's basically a combination of what everyone said. So there were new consolidative opacities mixed with some micronodules, macronodular opacities, ground glass opacities, and some interstitial opacities with interlobular septal thickening throughout both lungs, and some small bilateral pleural effusions as well, and some reactive. Very much older CT. So given the history of epigastric pain and the melena, the patient did undergo an endoscopy. This one's a little harder to ask what the fellows what they might be seeing because it is a little dark. So I'll describe the findings. So these are, and by the way, these are all actual pictures of the patient, of course. So these are the images of the second portion of the duodenum that we're looking at. So the EGD findings for this patient was normal esophagus. And then we had erythematous mucosa in the stomach with large amounts of dark red blood clots. There was evidence of severe duodenitis that was characterized in these images above with erythema, congestion, and very friable dusky mucosa. Biopsies were taken from these locations. So I'll pause here for a case discussion from the fellows about what their thoughts are about the differential diagnosis and additional kind of management plan or whatever else they may want to pursue.
So it looks like there is chest involvement, and also there is GI involvement is there in immunocompromised. So for me, it can be like CMV pneumonitis with CMV gastritis.
other differential is PJP, as the patient is hypoxemic and immunocompromised. PGMP and CMV are the histoplasmosis. Aspergillosis.
Histoplasmosis can be there, and the patient is in that region, and another differential would be some other atypical type of pneumonia, that is atypical type of pneumonia. H influenza can be there, and H influenza can also be caused of pneumonia. And furthermore, she is a resident of Mexico, where TB is also prevalent, so this can also be morbidity in case.
COVID pneumonia.
COVID also.
So for the fellows, please note that this patient had contact with animals as well, and she had a significant animal captive exposure. She was in rural Mexico, so the geographical area is important while you make your differential. So what else can, we have heard about CMV, which is a possibility. We heard about PJP. PJP would not explain the duodenal finding. Then we heard about histoplasmosis, which will give more of a pancytopenia, but it can give pneumonitis. Okay. Anything else? But then it would not explain the duodenal finding. You've got to keep the duodenal finding.
All right, so I think
So,
we're off.
so people, so sorry, so people who are discussing on site, can you speak a little louder? We could not hear on the Zoom.
I think so. Some of the fellows here were commenting on histoplasmosis, aspergillosis, invasive fungal infections. Given the background in the kind of endemic area in the US, there were comments again on TB, CMV, PJP, amongst others. So I think that's a good starting differential. The thing to recognize is that this is a lung gut syndrome. So we have evidence of a pneumonic process with duodenitis that's bad enough to cause upper GI bleeding. So, CMV was mentioned. Any other etiologies that may explain a lung duodenal syndrome?
So we've got some comments on the chat box, which are Coxy and endemic mycosis, Legionella, Brucella, and protozoal infection, not specifying which one. And people are also asking what the eosinophil count was.
The eosinophil count here was normal. I'll go back to the CBC as well just to share, but there was essentially all, the white count was 13,000. It was essentially all left shift with a normal eosinophil percentage and normal absolute eosinophil count. All right, so I think we'll move on to the fun part. So this patient underwent a bronchoscopy, and this is what was seen in the BAL wet mount. And I'd like one of the fellows to identify what this is. And I think we also may have some micro residents.
Bedding keys clear.
Focusing in on what's in the center of the image.
So we would like fellows to comment on what they're seeing on this BAL wet mount. It looks like a worm, round worm.
Great. What roundworm might you be thinking of for this patient's context? From Mexico?
Strongylized.
All right. Very good. Any other comments?
Buffer syndrome से होता है lung and
Sorry, we can't hear you.
All right, let me move to a closer image zoom in. So this is the same pictures, same patient's image. So Dr. Noor, your comments on your differential, the things that you mentioned, it's a bit more clearer in this picture.
It look like a roundworm and maybe ascaris or stingulitis.
All right. So that's great, Dr. Noor. That's perfect. So this is a roundworm, right? Because it's nice and round. And what we're seeing here is the anterior part of it and then the tail. And so keeping everything in context for this patient, let me actually move to the H&E stain of the EGT biopsy as well, just to highlight that. So here, what we're seeing is for this particular Nemo or nematode, we're seeing here the adult forms, the larval forms, and the egg forms. So we've got some adult forms in the upper arrow, and in the middle we've got some larval forms. Then down here we have some of the egg forms, and lots of duodenitis with inflammatory cells in the surrounding area. And this is a 100x zoom of the same thing, where you can actually see this worm, this roundworm on the EGD biopsy. Once again, seeing the adult forms, the larvae, and the eggs. The other evaluation for this patient was negative, but what the BL cytology also confirmed was that this was an organism morphologically consistent with strongyloides. All the other evaluation for routine cultures, Legionella, viral biofire, PJP, PCR, fungal cultures, AFP cultures, gene expert, all of that was negative. And on the EGD as well, it demonstrated severe duodenitis with numerous parasitic forms of strongyloides stercoralis. Stains were negative for GMS, AFB, CMV, EBV, and HSV from the duodenal biopsy. So our final assessment was strongyloides hyperinfection syndrome, with involving both pulmonary strongyloiditis and severe duodenitis. So any comments on this case so far? Does it make sense?
What could be the reason of harboring that scariasis? How she got it? In some meal or skin exposure?
Right. So absolutely. So great question. So she's originally from Mexico. She's lived, about 50 plus years in Mexico. She used to own a farm, work on a farm, live on a farm. And so most likely it is endemic in Mexico. So most likely acquired through skin exposure while working on the farm. And thereafter, any of the fellows, if you'd like to comment on why this became a problem for her now.
She's immunocompromised. It's steroid immunocompromised.
Exactly. So she took a bunch of steroids appropriately for what was paclitaxel-associated pneumonitis, but it was living inside her, and thereafter, following the steroid exposure, she developed hyperinfection syndrome. So in the interest of time, we'll kind of move along. So onto her hospital course. She was treated with daily ivermectin. She also received empiric antibiotic coverage to cover for any enterogram negatives that might have been riding along with the strongyloides. She was fairly sick back then. She did have some degree of hypotension and then shock as well, because she was bleeding as well at that time. With the ivermectin and while on antibiotics, she did have improvement in her GI bleeding and respiratory status. Her steroids were, of course, stopped. It was recommended, and I believe it was stopped back then. However, throughout, again, in her hospital course, she did have recurrent worsening of her hypoxemia. A CTPE at that time identified a small subsegmental PE, and it was one of those overnight assessments that led to anticoagulating her for that relatively small but PE in the setting of hypoxemia. So by the next morning after she was started on anticoagulation, within the next 24 hours, she had massive GI bleeding, refractory shock, cardiac arrest, and unfortunately she passed away. So we're going to talk about strongy. So this is a roundworm. It's a nematode with a complex life cycle. Originally reported in 1876 in the stools of French troops in Vietnam, and it does affect a large number of people worldwide. This includes territories in South America, Latin America, even the US, Africa, Asia, and Australia. This is data taken from 2013 from neglected tropical diseases. The life cycle of strongy is very interesting.
Amir, can I interrupt for 1 second? Sorry.
Sure.
Can you just go back one slide? I just want the fellows to realize that it's sort of unlikely that the disease skipped Pakistan and went straight Aage. So just the fact that it's white and there's no data is almost certainly going to be strongyloides in this part of the world.
That's an excellent comment, Dr. Faisal. In fact, even in the US, a lot of times, so it does show India as light yellow, for example, but even in the US, a lot of cases that we would see of hyperinfection there would actually be migrants coming in either from Latin America, South America, or India. So we did encounter that a lot, and even talking to some of our colleagues in India where they would see this commonly enough. For example, in the pre-transplant evaluation programs that would collaborate with India, they would be seeing a lot of strongyloides serological positivity in India. So it seems unusual that Pakistan got skipped altogether.
Dr. Faisal?
Yes.
Dr. Faisal, just to comment on this, I mean, we have a lot of ascaris in our childhood population, in our peds population. So, but we, and I mean, obviously, we haven't seen the strongyloides as much in the stool samples. I mean, no comment about it. It's usually ascaris or Trichuris trichura, which is usually coming up.
Afia here, no, we do see strongyloides stercoralis in stool specimen. At times, the larvae of strongyloides is difficult to differentiate with other larvae, but we do see. ऐसा नहीं है कि हमारे पास है ही नहीं. It's here.
लेकिन कम होता है ना? मतलब generally जितना हमें ascaris मिलता है, predominantly we have more ascaris here.
हाँ, exactly. हाँ, ascaris ज़्यादा है और strongyloides देखते हैं.
हमारे पास डेटा क्यों पब्लिश नहीं है, मतलब इसके बारे में इतना?
ये हमारी नालायकी है.
बस डॉक्टर आफिया आप पब्लिश करें ताकि हम भी येलो हो जाएं.
इंशाल्लाह. आजकल लगे. हमने पहले माइसिटोमा पब्लिश करके हम मैप में आए, अब आजकल हम क्रोमो के पीछे पड़े हुए हैं. फिर मेरा ख्याल इसको भी करेंगे. आप सही कह रहे हैं फैसल. इट्स वेरी करेक्ट. वी शुड बी ऑन द मैप. और जवेरिया हमेशा यही कहती है हमें एटलीस्ट मैप पे तो होना चाहिए. Good suggestion. We will see what we can do. Thank you.
But I can tell the fellows that strongyloides does show up in the exams for sure.
Dr. Asma had one case in a transplant patient. She discussed that case with us. I don't know if SIUT can comment about it, but I think they saw strongyloides hyperinfection in a transplant case.
Or maybe after Amir is done. Sorry, I interrupted Amir beach me and we started discussion.
Okay.
Sorry, Amir.
Not at all. Thank you, everyone, for those comments. So the life cycle is interesting. There's part of it is inside us, and then the other of the what's on the right. What's in red is outside the human body. So we'll start from number 1, where the larval form is excreted from the intestine into the stool. And from there, it will develop into an adult worm, and then eggs are produced by fertilized female worms, and then those eggs will kind of hatch into more larvae. And then that filariform larva is really what will penetrate the intact skin of the definitive host, which is humans. And then through the skin, it enters our bloodstream, goes into our lungs, from there swallowed into our GI tract. And that's how the adult worm lands up inside us. Now, very interestingly, the female in the small intestine The female worm, the adult parasitic female worm is actually able to reproduce asexually and form eggs on their own. And thereafter, that egg that you're seeing in figure 9 has one of two choices to make in life. It can either continue to cause what is called auto-infection inside the human host by from becoming an egg, going into worm form, and then again undergoing asexual reproduction, and that cycle of auto-infection continues inside the large intestine, and that's really what allows a large worm burden to really lead to hyperinfection. Or it can venture out into the world through our stool and become a larval form again, and then go on to infect us through soil and whatnot. Dogs may also serve as definitive hosts for this cycle. So autoinfection is this unique ability of Strongyloides to complete its life cycle within the human host. And typically it is limited by an intact immune response. And I'll talk about that in a couple more slides. If people who are infected may become asymptomatic or mildly symptomatic carriers for long periods of time. And in fact, it's been described as even kind of carriers carrying the worm for even up to like 60 years or something like that in the literature. So typically, though, in an immune competent host, it will be taken care of by the autoinfection is limited by our normal host response, by our Th2 response, or there are mild symptoms of maybe vague abdominal pains. So just going over the process of human infection. So the larva is going to penetrate through the skin, typically through the feet, because it's found in the soil. And that's where it may form this rash, if you will, of cutaneous larva currents, where what that basically implies is that there's a larva running around in the skin, and that's what it appears as well on examination. And this is an urticarial reaction to migration of the parasite. So you have a rash and it's very itchy and you see a worm running around in your skin. Sounds scary, actually. Now from there, from the skin, the worm will travel to the lungs. Here it can reside and cause wheezing, cough, and hemoptysis. This has been described as Loeffler syndrome. And from the lungs, it's swallowed into our gut, down into our small bowel and our duodenum in particular, where it can cause duodenitis, obstruction, or strictures. This process can repeat itself with large amounts of larval ingestion into our gut and then going back into our blood and lungs. And this process or this vicious cycle is what leads to hyperinfection syndrome, as it did for our patient. And mute yourself. We're just getting some echo.
थोड़ा सा करने का टाइम तो मिल जाएगा, लेकिन बात डॉक्टर ईशान की भी गलत नहीं थी कि वहाँ किसी ने तुम ऑब्जर्व कर लिया.
Everyone could please mute themselves. Thank you. So if there's overwhelming autoinfection, it can disseminate, and as the worm travels through the intestine, other bacteria can ride along the meningitis, sepsis, and death, and that's what
Arsalan, can you mute yourself? Arsalan, mute कर लें please. और लुकमान, can you mute or something?
अनुषा नाम है, क्या नाम है मैडम है इसकी सीनियर जो?
Arsalan. Thank you. Sorry.
Thank you, Dr. Professor. All right. So it's one of those causes of meningitis with, let's say, E. coli meningitis, for example. So whenever we come across gram-negative meningitis, we might want to consider that the worm's kind of traveling through the body, entering the CSF as well, and it's carrying with it gram-negatives from the gut and as a result of the duodenitis. GI manifestations. So since the adult worm lives in the small bowel, it can cause trouble or symptoms from there. So upper abdominal or epigastric pain, diarrhea, anorexia, nausea, vomiting. Food ingestion may aggravate that pain. They can present with a chronic enterocolitis and malabsorption from a high intestinal worm burden, duodenitis, obstruction, and strictures. So as you can imagine, there's a lot of overlap in terms of these chronic GI symptoms with other chronic things, whether it might be IBS, IBD, abdominal TB. And so doing endoscopy or really bronchoscopy to identify it is quite useful. Pulmonary manifestation. So there is transpulmonary migration of the larva, and therefore every time that happens, there are repeated episodes of fever and pneumonitis, or even an asthma-like syndrome that can paradoxically worsen with steroid use. Pulmonary infiltrates can exist along with alveolar hemorrhages, and when hyperinfection syndrome is occurring, that can progress to ARDS, interstitial infiltrates, fibrosis, lung abscesses, cavitary lesions. Fortunately, though, on a BAL wet mount, it's fairly easy to diagnose, because when there is hyperinfection syndrome, as soon as that wet mount is placed under the microscope, one will easily appreciate the strongy worm forms in there. So it's actually kind of doing the BAL is really helps as far as diagnosis and differentiates it from all the other differentials. Dissemination involves overwhelming autoinfection, high parasite burden with penetration of mucosa, intestinal mucosa, leading to bloodstream dissemination to multiple organs. This is accompanied by systemic inflammation, organ dysfunction, shock, bacteremia, as the bacteria can ride on the backs of the larvae, meningitis, pneumonia, as I mentioned, gram-negative meningitis as well. And the usual cause of death is due to secondary bacterial infections. And so typically in the setting of hyperinfection, providing some kind of empiric gram-negative and or gram-positive coverage is considered appropriate. So the risk factors, the biggest risk factor is immunosuppression. But kind of looking into that a bit more specifically, the risk is increased if cell-mediated immunity is impaired. Now, we have two arms. We have the Th1 arm and the Th2 arm, and both of these arms exist in a seesaw balance typically. So Th2 is protective against worms and strongyloides, and that is through interleukin response that enables mast cell degranulation and IgE production with eosinophilia. And so that Th2 response is going to help contain worm burden and autoinfection and all of that. Th1 induces the release of interferon, which inhibits Th2. So anything that's going to trigger a Th1 response is going to be bad, and it can lead to hyperinfection. So, for example, the culprit in this case is steroids. So steroids promote a Th1 response. They inhibit that Th2 protective mechanism, and therefore allow that autoinfection and subsequent hyperinfection to occur. Other risk factors would be pre-existing lung disease, underlying malignancy, malnutrition, alcohol, transplant, HIV/AIDS, HTLV1, steroids, other cytotoxic drugs, and anti-TNF. Interestingly, though, it has not been described as commonly with HIV as it has been with these other immunocompromising conditions. And in the literature, even short courses as short as even 1 to 2 weeks have led to cases of hyperinfection. For diagnosis, eosinophilia can be useful. It can be a good clue. However, note that in hyperinfection, it is often absent. So absence of eosinophilia has actually been identified as a poor prognostic sign. And just like in our patient, as is seen with hyperinfection, eosinophilia is absent. Identifying eosinophilia is decently sensitive for intestinal strongyloiditis, but it is not seen with hyperinfection. And so, you would typically not find eosinophilia with hyperinfection. And additionally, in the presence when steroids are used, eosinophilia may be absent. So as occurred for our patient. Serial stool examinations are typically performed in combination with serology, or if specimen examination with sputum, BAL, ascites can be done, or biopsy. Now, larval output in stool is typically quite low and intermittent in chronic infections. And studies that have looked at sensitivity have found very poor sensitivity of one stool sample as low as 30%. And increasing the number of stool samples will increase the sensitivity rate. Typically 7 or as close to 7 stool samples are recommended to improve the sensitivity. Nonetheless, with chronic intestinal strongy involvement, you may still miss it because it's intermittent shedding of the worms. So serology does exist for both Strongyloides ratii and stercoralis, and larval antigens have been used to develop these serological tests. Commercially available ELISAs do tend to have good sensitivity and specificity upwards of 90%. And there are additional recombinant antigens used to develop ELISA tests. These are less common. Molecular methods are limited to research labs, and these are not standardized. Serology is typically the one that is obtained is the IgG antibody. Now, the issue is that it can be false negative as it cross-reacts with filariasis, ascaris, and schistosomiasis. And with treatment, with successful treatment, the antibody IgG can turn negative. And of course, if you have a positive antibody test, you still have to figure out whether it's an active infection or a historical case. Treatment-wise, so the big thing with treatment is, of course, because it's a neglected tropical disease, there's not a whole lot of data. Whatever recommendations do come through the CDC or kind of other leading review articles, a lot of it is based off expert opinion and smaller kind of or lower quality evidence data from case series and reports and whatnot. And so for treatment for acute and chronic infection is typically ivermectin at 200 micrograms per kilogram per day. This is first-line therapy. This might be used for 2 consecutive days or 2 weeks, a single dose is 2 weeks apart. Both oral and rectal formulations are available. And otherwise, albendazole for 7 days is alternative therapy as well. And typically, it is recommended to do follow-up stool examinations a few weeks after treatment to confirm clearance from the stool. For hyperinfection and dissemination, this is where the optimal treatment is uncertain because the data is limited and it's very much expert-driven. It's important to reduce immunosuppression. And typically, treatment is with ivermectin daily until stool and sputum turn negative, which may typically take 2 weeks, and definitely treating until the patient has clinically improved. Some experts in the setting of hyperinfection do recommend combining ivermectin with albendazole. And that's pretty much it. So finding Nemo was the nematode and Hyperspace was hyperinfection. Thank you so much, everyone, for joining in. Any questions or comments?
So we have a few questions in the chat box. I'll start with Dr. Faisal's question, which is, do we do wet mounts routinely on BAL? Because otherwise we'll miss them. And can it be done on sputum as well?
Thank you. I think talking to at least our microbiology colleagues, they do a BL wet mount. And I believe they do it fairly routinely. Let me see if our colleagues from micro are here. Maybe they can comment on whether it's whether it's routine for them to do it every time. But typically, my understanding with the bronch and BAL is that step 1 is to place it on a wet mount to try to identify any organisms too. So I believe it should be kind of as part of standard of care for this, but
I don't think it's done in Pakistan.
No, we don't do it. No, we don't do it. And I think unless and until there is a request, otherwise BL wet mount, we don't do it. No, it's not a regular practice. and it's not recommended. But if there will be something in the history, then definitely micro will do it. But on each sample to introduce in the lab, वो resources का मसला और दूसरे बहुत सारी बातें शुरू हो जाएंगी. लेकिन इसको सोचा जा सकता है if we work in a transplant unit or in a center where there are too many immunocompromised person admitted in the hospital, तो जब भी कर सकते हैं, वरना हम नहीं करते.
Assalamu alaikum, Nazia from Indus. So I
आवाज ब्रेक हो गई.
नहीं करते और अगर कोई कम्युनिकेट किया so I'm trying my level best कि आपको आवाज आ जाए. बस मैं इतना बताना चाह रही हूँ कि we don't do this at Indus as well, but if there is a communication from the clinician side that you are suspecting this, that we can think about it.
Okay, then we have another question. How to diagnose this? Are there any screening tests pre-transplant?
Yes. So thank you for those comments, Dr. Nazi, and I think Dr. Afia as well. So in the US, where I should probably backtrack a little bit. In the US, the center where I was, because we were both a kind of a cancer setup, we had a cancer setup and a transplant setup. So there they were doing routine BL wet mounts, and also because we were seeing a lot of people from Latin America and a lot of immigrant population. So maybe that's why they were doing it there. But thank you for correcting me that we're not doing it here routinely. Now, as a part of pre-transplant evaluation, it is certainly we do check strongy serologies, especially when we are dealing with a potential candidate who is from an endemic area. But as a matter of fact, since a lot of, for example, in the US, where a lot of transplant centers are seeing a lot of immigrant, are kind of catering to a lot of immigrant population from all over the world for their transplant evaluation. Majority of the transplant programs in the US have incorporated a strongy serology into their routine testing panel, at least in cities like Chicago or Houston, which have a large Hispanic population. I think in certain parts of the East Coast, where they might be catering just to a Caucasian population, they may not have it as a part of their standard protocol. But yes, a lot of several of the centers I've worked at did have it on their screening panel.
So, any comment about Pakistan transplant centers? Do we screen for strongy?
We don't screen routinely. Neither we do the wet mount, and कभी हमने देखा नहीं कोई patient ऐसा, लेकिन maybe we didn't diagnose the patients. A patient who come with bad bilateral infiltrates. So yeah, we don't do it in SIUT.
Great. I think there was a question: how did we confirm disease clearance in your patient? So our patient died from massive GI bleeding and shock. So unfortunately, we never got to that. HTLV, yes, Dr. Faisal's comment. HTLV and strongy is one for the exam.
Any other questions?
Yes, and Dr. Naseem, the PE was confirmed for our patient. A PE was confirmed on a CTPE protocol that led to anticoagulation and subsequent massive GI bleeding.
And the serology is ELISA. It's ID
Yes.
ELISA.
Yes, it's the ELISA.
So also my question is, how is the prognosis if it is a hyperinfection syndrome versus it is simple asymptomatic or symptomatic? So the management plan according to them, and how many days we can treat in hyperinfection syndrome?
Yes, so typically with hyperinfection syndrome, these will be fairly symptomatic and sick patients. And because the data is limited, but the overall prognosis is not great. There is a relatively high mortality in certain case series that I saw. It was as high as anywhere between 30 to 70% that was reported. And typically the cases where the mortalities occurred, these were immunosuppressed patients, heavily immunosuppressed patients with an overwhelming hyperinfection with bacteremia and septic shock and delayed presentation, which tends to be the case. So it is associated with high mortality usually.
I have a question, Dr. Amir. In this case, I guess you must have sent a blood culture. Did it show any gram-negative growing or not?
It did not. We did do multiple blood cultures, I believe 3 to 4 sets, and all of them returned negative. We were, however, we were able to diagnose this patient quite early during her admission course, and therefore we had her on empiric antibiotics really from the very get-go.
So that's about it.
Thank you so much. Thank you so much, everyone, for your attendance and participation.
Excellent work. Thank you.
Excellent. Yes, thank you.
Yeah, thank you.
Thank you.
Thank you.